Hearty good morning to our viewers today. I am Sana Fahim from Times of India. I would be the moderator for the event today. We welcome you all for a webinar with great knowledge in the field of medicine from the city of Joy, the city of Kolkata. In the current scenario of a pandemic, the anticoagulants remain one of the most important pillars of therapy, despite the usage of anticoagulants since being used since long in DVT, dialysis, or even in IVF. The topic of today's discussion is anticoagulation insights for clinical management, brought to you by the Times of India in association with Biological E Limited, one of the legendary anticoagulant producers in India. We have an expert panel of doctors here with us. We'll start with introducing our expert panel, esteemed panel of doctors here, all senior doctors, experts in their field. I'll introduce the first doctor, Dr. Syamasis Bandyopadhyay. Dr. Syamasis is a senior consultant, physician, rheumatologist, director of medical services at Apollo Gleneagles Hospital, Kolkata. Welcome, Dr. Syamasis. The next doctor is Dr. Aviral Roy. He is the co-director and consultant physician, critical care unit, Medica Super Speciality Hospital. I extend my welcome to you, Dr. Aviral. Then we have Dr. Ajoy Sarkar, clinical director, intensive care unit, Peerless Hospital, Kolkata. Welcome, sir. Welcome, Dr. Ajoy. And the next one is Dr. Partha Pratim Ghosh, consultant physician, Zenith Super Speciality Hospital. Welcome, Dr. Partha. We welcome you to this discussion. Very insightful webinar, I'm sure it is going to be. Without further ado, since we have all the doctors here already, we'll start with the discussion with the Q&A session. So I'll pose my first question to Dr. Syamasis here. Dr. Syamasis, this question is for you. What are anticoagulants and how are they different from antiplatelets like aspirin?
See, in the coagulation process in our mammalian body, what happens that the key element is the platelet. And platelets, they do aggregate or they stick to each other as we call it. And on that platelet stickiness is taken care of by drugs like aspirin. And that's why they are called antiplatelet drugs. Aspirin, clopidogrel, stuff like that. Ticagrelor, stuff like that. So they reduce the stickiness or adhesiveness of the platelets. Because anticoagulants are molecules which attack the coagulation process in various areas through the coagulation factors, and they do not allow clots to be formed on the platelet adhesion or platelet stickiness area. So at the end, you must have a clot, which is a blob-like thing composing the coagulation factors, which are proteins essentially, and some platelets. On that, there are structural changes in the coagulation factor proteins, and that make a blob, a small, like a blob. And that is the clot, which goes and occludes the flow of the blood in various areas of your body. This process of coagulation is tackled by anticoagulant. So there are various natures. The first one of that kind, as you all know, is heparin. And from that, it has progressed further. From heparin, then there was low molecular weight heparin. Then there was currently a thing called NOACs. Things have progressed from that, but the fundamental thing is blocking the coagulation processes at various points so that the blobs or the clots cannot form.
Thank you. Thank you so much, Dr. Syamasis. That was indeed insightful to know about the progress of the anticoagulants. My next question is for Dr. Aviral. Dr. Aviral, what are the various oral and injectable anticoagulants available for clinical use?
Thank you, Sana. So this is a vast topic. In fact, we can have an entire conference just on this one question, right? So anticoagulants are multiple proteins. If you look at what's called the coagulation cascade, there is not just one protein or two proteins, but actually a combination of 12, 13 proteins and various steps that are taken to make those proteins. So that is where the drugs, what we call anticoagulants, work. Either they work directly on these proteins to stop them from functioning, or they stop the production of these proteins. We'll first talk about injectables. Uh, One of the first injectable anticoagulants, as Dr. Syamasis just mentioned, was heparin. So that was the first one. And from there came a bunch of other molecules, like what's called low molecular weight heparins, like enoxaparin and dalteparin. Then from there came another line of drugs called antithrombins, like what you call what we call fondaparin. Fondaparin is a type of low molecular weight heparin. Then you get bivalirudin, which are another group of all injectables which directly block the functioning of proteins. Then you come to oral anticoagulants. They are called in two classes. One is called a vitamin K antagonist. What they do is they stop and block the production of coagulant factors by the liver. So this is what was a classical oral anticoagulant, what we call warfarin, which is the first of its class. Now you have a few more that are coming that are there, but warfarin is still the prototype drug. That is the first oral, and after that, now you have directly acting novel oral anticoagulant agents, which are tablets that you take and they block the functioning of proteins. These are newer molecules like apixaban, rivaroxaban, etc. So these are the major drugs that are there in the functioning of anticoagulants, both injectable and oral.
Okay. Okay. Thank you so much, Dr. Aviral. That was indeed insightful. You shedding light on the oral and injectable anticoagulants. And I heard you mentioned warfarin there. So on that note, I would like to address my next question to Dr. Ajoy. Dr. Ajoy, what are the problems with warfarin exactly?
Dr. Ray already mentioned about the warfarin. It's a vitamin K antagonist, and we have been using this for years together. The problem with this medicine is that it has got a very narrow therapeutic index. The therapeutic effect and the toxic effect is a gap between is very small. So therefore, it's very important to monitor the INR, we call it international ratio, and that INR should be between 2 and 3 in general, but there are certain situations where we need to keep it above 3. But this is one of the problem with this medicine, because you've got to estimate this INR. Now, problem in our country is that this estimation varies from lab to lab. And if you see somebody is coming with an INR of 2 from one lab, next time he is getting it checked from other lab and which is showing 1.5. So you are not aware. That is my practical problem with warfarin. And another important problem is drug-drug interaction. So there are lots of drugs which can interact with warfarin in the form that it can increases the effect of warfarin. So there will be chance of having bleeding, severe bleeding. Say, for example, if you are using amiodarone, which is very commonly used drug in cardiology, and if you want to give warfarin, then you have got to remember that this amiodarone can increase the INR when you are using warfarin. So there are lots of antibiotics and other commonly used drugs which can interfere. So one should remember that that is the limitations of warfarin, and that is why we are trying to find out a newer generation anticoagulant, oral anticoagulant, and we have got that already he has mentioned, and that has got the advantage that we don't have to monitor the INR or therapeutic range in that group of drugs.
Thank you. Thank you, Dr. Ajoy. So basically, we are trying to look for newer generations of anticoagulants which are better, far more effective. Thank you for the answer, sir. And my next question on that note is to Dr. Partha. Dr. Partha, we are constantly talking about a newer generation or better anticoagulants here. You know, all the doctors are basically speaking about it one way or the other. So which are these newer anticoagulants available as of now?
It's basically continuation of what Dr. Sarkar said already, and Dr. Roy. We basically have two types of oral anticoagulants. What we were using so long are vitamin K antagonists, that warfarin. That's being used so long. They have some problems, but they are being used very long. So the newer anticoagulants, what we have, those are non-vitamin K antagonists. They are known as NOACs. Okay, new class of drug. We have 3-4 molecules already: rivaroxaban, apixaban, dabigatran, and being used for the last few years. There are some advantages with these drugs. They have a very good favorable PK/PD ratio. So what happens? These drugs are they are predictable, much predictable than warfarin. With warfarin, what's the problem is we have to constantly monitor, and you have to change the dose accordingly. It varies with the food, it varies with age, it varies with even individual patients have to be tested every 4 weeks, 5 weeks, like that, and has to be adjusted accordingly with warfarin. But with NOACs, that is not much required. It's an advantage. It acts very fast. It's a faster acting. And the drug-to-drug interaction activities are, much less. But they are newer drugs. We don't have very much experience on it. And we are using it right now. They have some advantages, but they are costly, and they have some disadvantages also. We can discuss later on.
Okay. Thank you. Thank you, Dr. Partha. So a lot of research and new technology and new research needs to be done, actually, I think. And my next question is for Dr. Aviral again. What are the various cardiovascular diseases in which oral anticoagulants are used?
So once again, I'll call the old drugs, the warfarin, let's just call them vitamin K antagonists, what we call VKA. And what we call the newer agents, we'll just call them NOACs. So this is just a terminology we're going to use. So everybody understands what we're talking about. Now, all of our research since the 50s and 60s have been done on the VKAs. So they are still, and they continue to be, the drug of choice for all cardiovascular diseases because they have been tested on all of them. Now, as far as the heart is concerned, we have two main categories of diseases. They have valvular heart disease, where the valves of the heart are actually not working well or have disease in them. And we have non-valvular heart disease called AFib, which is atrial fibrillation, which are the primary indications for anticoagulation. All of these VKAs are indicated for all of the above. Now, depending on your specific heart disease, you have different targets. So if you, example, have aortic valve disease, you might require warfarin in the range of 2 or VKA for an INR range of 2 to 3. If you have mitral valve disease, this goes up to 2.5, 3.5. But in valvular heart disease, the only oral drug you can use is warfarin. For non-valvular heart disease, you can use the NOACs, which are the newer agents. They have been shown to be equally effective, if not more, as compared to VKAs. But in places where you have valvular heart diseases, these drugs have been shown to be inferior. So for valvular heart disease, you have to use VKAs or warfarin. But for non-valvular heart disease, atrial fibrillation, you can go ahead and use the NOACs.
Okay. Thank you. Thank you, Dr. Aviral. So we are discussing VKAs and NOACs, as Dr. Aviral pointed. Thank you, sir, for that. My next question is to Dr. Syamasis. What is the role of anticoagulation in critically ill patients, sir?
Thank you. It's a very difficult and complicated question as I have understood it. There are two sets of, if you can broadly categorize patients in the hospital, is medical hospitalized patient and surgical hospitalized patient, i.e. orthopedic, surgical, surgery, stuff like that. And critically ill patients in critical care unit and in ward setting. That's how you can very broadly differentiate people. Now, for surgical thromboprophylaxis, as we call it, that means we all know that prevention is better than cure. So to prevent thrombus to happen, for surgical patients, thromboprophylaxis or given some sort of preventive anticoagulant, almost always injectables, can always be heparin, but the problem you've already heard and learned that heparin has got this monitoring issue because you don't know how much heparin will be needed to achieve that level of APTT, which we monitor to see how heparin is working. And also heparin has got more chance of thrombocytopenia, meaning fall in the platelet count. So we call that as a HIT or HIT. heparin induced thrombocytopenia. So heparin has got its issues, and that's one of the driver for so many other medicines to come up over time. But for surgical thromboprophylaxis, some sort of low molecular weight heparin like enoxaparin is one of the most used medicine in the whole world as a prevention measure. For medical thromboprophylaxis for admitted patient, the multiple meta-analysis has failed to show similar power of success as in surgical patients. That doesn't mean that I'm saying do not give anticoagulant to medical patients. What I'm trying to highlight that medical patients have got a lot of complications for which they have come to the hospital. It's very unlikely for one single medical reason somebody has come in, and often they have got other illnesses as well, including a history of stroke or bleeding and stuff like that, GI bleed, so on and so forth, nephropathy. So one has to really judge individual patient before they prescribe the anticoagulant, and also what drug they can prescribe, because lot of issues, like for example, I'll pick up one. You don't want to give one variety of low molecular weight heparin to patients with renal failure. You would prefer the other one on top of. So these are very basic things in medical ward rounds, but they are important. So one has to realize what particular anticoagulant to be used, and some of the anticoagulants also cause the low molecular weight heparin fall in the platelet counts. So if you've got lower platelet count to start with, you might want to prefer one variety of injectable over other because of further fall in the platelet. So medical thromboembolic prevention is slightly more complicated than the surgical. For critical care ones, you know that because they're immobile for such a long time, unless there is some reason not to give them some sort of thrombo prevention, like somebody has got intracranial bleed or some sort of active GI bleed or stuff like that, they should all get some form of anticoagulation. And in those cases, there are options, mechanical options available to be used for prevention of formation of clot in the leg, which is the commonest site, rather than not doing anything at all. So that's how I see the game.
Thank you. Thank you, Dr. Syamasis. You've actually shed light on this. In critically ill patients, the doctor has to use their best medical expertise and judgment. It is a very complicated judgment nonetheless. So thank you, Dr. Syamasis. We'll move on to the topic of atrial fibrillation. And since Dr. Aviral has already mentioned it last reply, so I'll move on to Dr. Ajoy for the next question. Dr. Ajoy, how do we prevent stroke in patients with atrial fibrillation?
So already we know that atrial fibrillation is one of the commonest cause for stroke, and the stroke, thromboembolic stroke, we mean it. And since it can cause thrombus formation in the atrium or atrial appendages, and that can dislodge and go to anywhere, not only stroke, it can cause peripheral vascular disease and obstruction. So question is, we have to find out whether this atrial fibrillation is transient or it's permanent. There are few terms we use for atrial fibrillation. Like for transient, we call it paroxysmal atrial fibrillation, which means that fibrillation is not lasting more than 7 days. So in that situation, again, you have to judge, because whether giving anticoagulant can cause bleeding as well. So we are using some scoring system, CHADS VAS scoring system, which means congestive heart failure, hypertension, age above 75, diabetes, and previous episodes of stroke, apart from vascular events other than an age below age 65, and also sex, female. So these scoring, if it is 0, and if your atrial fibrillation is less than 7 days, we should not use. On the other hand, if someone has got a persistent or permanent or long-standing, more than 12 months, there the question of incidence of stroke is quite high. Again, you have to go by this CHAS2 scoring system. And that scoring system will give you, if the point is between 0 to 2, the chances is less. Between 2 to 4, chance is moderate. And if you more than 5 to 6, then chances is high. Where the chance is high, you got to give them anticoagulant. And better in this situation, I would say that if the patient can afford to go for DOAC or NOAC, they should go for that, because they have to continue for years together. And there are situations where one can have many drugs, and with even food, warfarin can interfere. So, but here the question will not arise and monitoring will not arise. So it's important. So many issues you need to bring in that questions, that whether your charge score is high. Again, Hasblad, another scoring system, we go by that, the chance of bleeding. If it is there, the bleeding chances is very high and your risk is mild or moderate, probably will not go for anticoagulation.
Thank you, Dr. Ajoy. The scoring system you mentioned just now sounded to me, something like ABGAR scores. So, yeah. That is for another part, obviously, for the babies, but this one is something I think, I could get the concept quite clearly the way you presented it. So thank you, Dr. Ajoy. My next question is for Dr. Partha. Dr. Partha, how do we monitor for effects of anticoagulation in various situations?
Basic thing is to monitor the anticoagulation effect. We have to go for a blood tests that it's P time and INR, international normalization ratio. So in every aspect, we have to maintain that P time and INR. Accordingly, we use whatever anticoagulant. For warfarin, we have a basically protocol, and what amount of INR should be for which disease, that's all been Dr. Roy already discussed. But for heparin also, we have to monitor this P time and INR, because if you use more drug, it will lead to bleeding. If you are using less of the drug, it may not help you to prevent the stroke, what we are trying to do in atrial fibrillation. But the problem with the newer drugs, that is NOACs, it is not very easily monitorable, cannot be monitored so easily, but it doesn't require a regular monitoring also. Like what we have for warfarin, we have to monitor regularly every month or every 3 months, like that. For NOACs, that much monitoring is not required, but still there are newer tests coming up to monitor the effect of the basically NOACs, but those are very difficult to do. Right now, we in hospital setting, when the patients are admitted, we do regular tests. This P time INR and APTT is being monitored, and in OPD basis, the patients are being advised for the according to the next test to be done, when to be done, and the dose of the medicine is adjusted accordingly.
Okay, thank you, Dr. Partha. My next question is for Dr. Aviral. We've been talking constantly of atrial fibrillation. So I'll just come back to that for a bit. What are the alternatives? What are the alternatives to anticoagulants in patients with atrial fibrillation?
So first of all, we must understand why do people get a stroke in atrial fibrillation? What is this left atrium? The left atrium is actually a booster pump into the left ventricle, which then pumps blood to the rest of the body. Now, what happens in atrial fibrillation is the booster pump stops working. So blood is just passively flowing into the left atrium, into the left ventricle without this booster effect. As a result of this, there are certain dead spaces within the left atrium where blood will just swirl and collect. And it's called stasis. So when stasis happens, that is, blood is just lying in one spot and not moving. It'll tend to form clots over there. And sooner or later, one of the days, those clots will get dislodged and get pushed into the left ventricle, which is then pump it into the brain, where it goes to the brain, it causes a stroke. If it goes into the stomach, it can cause an infarct over there. Or if it goes to the legs, it can cause basically the equivalent of a heart attack in the legs or a stroke in the legs. So this is what happens. So why do you not want to use anticoagulation? Some people may be unacceptable bleed risk, right? They might have a history of bleeding the brain. They might have severe hemophilia, or they might have some other condition which makes them a high bleeding risk if you start them on anticoagulation. They might have a low platelet count, for example. What do you do? So then you might want to use a mechanical device that will go and obstruct those dead spaces in the left atrium where you want to use anticoagulation. So one of these is called the Watchman device, which is basically a small metallic cylinder that you place within the left atrial appendage, which is the most common site of this blood swirling and stasis, that effectively obstructs it. Another option is if the patient anyways needs open heart surgery for whatever indication, the surgeon might go ahead and clip that area off. That is, they apply a clip that basically shuts that area, so blood cannot collect in these areas. So those are realistically two major non-anticoagulant options for if you don't want to take anticoagulation and atrial fibrillation, and you're trying to reduce the risk of stroke.
Right. Thank you. Thank you, Dr. Aviral. Could I have the names again? The two devices, the Watchman.
There's only one device. The device is the Watchman device. Yes. And the other one is you just do during open heart surgery, they'll put a clip over there. They'll just clip the left atrial appendage off.
Right, right. Thank you. Thank you so much. Sure. So that sounded very interesting, even to a layman like me. So thank you, Dr. Aviral. My next question is for Dr. Ajoy. Dr. Ajoy, we are in the midst of a pandemic, and I think this is actually a very relevant question here we have. Is COVID-19 infection associated with increased risk of thrombosis, and how is it different from DIC?
Yeah, this COVID-19 has got direct effect on thrombogenesis, and it has been proved that in different studies have shown that the incidence of thrombotic events, as I said, that this COVID-19 has got definite effects on thrombogenetic events, and different studies have shown that the incidence of thrombogenesis varies from 20 to 50%. By and large, it can cause 1 in 4 patients thrombogenesis. And more important, that this thrombogenesis happens in limited area, not generalized. Say, for example, in most of the patients are having microthrombogenesis within around the alveoli. And that was the reason for their getting hypoxia in spite of not being affected alveoli. And that is why they don't get dyspnea. Unless you have got alveoli affections or airway affections, then you don't feel like dyspnea or breathing difficulty. So we call them happy hypoxia because the gas exchange is being hampered because of microthrombogenesis. And it happens due to the direct effect of the virus, due to the coagulation factor differences, and thrombogenetic factors and the thrombolytic factors, imbalance, and cytokines. There are many theories. I'm not going into that. But again, in one study has shown that it can cause DIC as well, but incidence is less than 1%. From China, they have proved. But the problem with DIC, when you say DIC, we have to go by the definition of international definition, where you got to have generalized consumption of anticoagulants, and the process will be generalized, not in limited area. Therefore, you got to have a severe platelet deficiency. Whereas in COVID infection, even with thrombogenesis, we don't get that much of platelet deficiency, maybe around 1 lakh or between 50,000 to 1 lakh. But in DIC, it will be less than 50,000. Second point is D-dimer in both the situation will be increased. That's why we are confused at one point of time, whether it's a DIC or it's a COVID-related thrombogenesis. But other point, fibrinogen, which is important. In DIC, fibrinogen will be always low, always low. At times, you may not estimate the fibrinogen, but here the fibrinogen level will be high. This one parameter will tell you whether you are dealing with DIC or not, apart from the other coagulation factors, which again can be low in DIC, but here you won't get. And incidence of thrombosis is very important in COVID-19 patients. Here, hemorrhage is more important. Of course, there are certain situations we might get hemorrhage from that area, but not generalized. So this is different from DIC. And we do have DIC in COVID-19, but incidence is very, very low. Whatever we are getting is thrombogenesis, and that can happen in organs, particularly lung, heart, cerebral. These are major organs. Even the kidney can get that. And postmortem study has shown that thrombogenesis, in one Netherlands study has shown that those who have died in spite of being on anticoagulant, not therapeutic, they have developed 80% thrombus, 80% cases thrombus. So it's so common in them.
Thank you, Dr. Ajoy. And I heard you say that D-dimer increases in both COVID and DIC. So on that note, I will present my next question to Dr. Partho. So Dr. Partho, what is D-dimer and how is its role in patients with COVID-19 infection?
D-dimer is basically one of the protein fragments that are produced when blood clots dissolve. So in COVID-19, we have a thrombogenetic state, and that produces blood clots in the body, and the clots start dissolving gradually. So that produces these particles, D-dimer. This is one of the part of fibrinogen degeneration products, FDP, we know. D-dimer is one of the products of that. So what is seen that the D-dimer levels higher in severe COVID disease, and they have some prognostic effect, and severity can be assessed up to some extent in COVID-19. So we have severe COVID disease, the D-dimer levels are usually higher. There are other causes that can produce a higher D-dimer, like a blood clot dissolving anywhere. So if you have an injury, a fracture, it can produce a high D-dimer. Even in pregnancy, you have D-dimers high. Even in surgery, you can have a D-dimer high, like that. But specifically in COVID-19, it's not straight away. You cannot say that this amount of D-dimer and you can grade the severity accordingly. It's not that. But in severe diseases, we have a higher D-dimer. So what it means more and more thrombogenetic state, and more blood clots are being produced and they are dissolving. To counter that, the D-dimer level has to be assessed, and we use anticoagulants in these patients. So to reduce the D-dimer level. If you can reduce the D-dimer level, it means that clotting and clot dissolution has reduced. So you have to use heparin and other anticoagulants in COVID patients. Okay.
Okay. Thank you. Thank you, Dr. Partho. In fact, talking of D-dimers, I think all of us in the second wave who were infected with COVID-19, we have become quite familiar with that term. Yeah. And thank you for helping at least me and our audiences make sense of that term, because it was always an enigma for us. What is a high D-dimer? How does it relate to this? So thank you, Dr. Partho. My next question is for Dr. Syamasis. Sir, what is the role of prophylactic anticoagulation in COVID-19 infection, and how long is it recommended?
I will first make a statement that COVID-19 is an evolving illness, and no recommendation is set in stone for any of the treatment options for COVID-19, and neither the evidences are strong enough to base judgment call. It is still a clinician's experience, prior experience, collective experience. Like people of Bombay may have got, so many experience of so many types of problems. They have found that this is the best option, so on and so forth. But overall, whatever we know currently is that for hospitalized patient for COVID-19, there is clear recommendation of anticoagulation. There will be no doubt about that, unless there is specific contraindication of bleeding of any site, or patients having intracranial bleed or some sort of bleeding manifestations already. Now, this is fairly evidence-based as we talk now, but this also can change over time. Now, in the second wave, which Sana, you picked up very well, a lot of people were at home who should have been otherwise hospitalized. There is a blur between who should be at home and who should be in hospital, depending on the availability of hospital beds all across the world. I know for certain in United Kingdom, in NHS, they are home monitoring a lot of people during their so-called third wave, because they also had problems with finding beds for those patients in a hospital setting. Because COVID-19 does not necessarily cause resolution of all other illnesses in the planet, i.e. you still need hospital beds for other patients. So if the entire hospital is full of COVID-19 patients only, where does other patients go? And that is an international problem. It's not unique to our part of the world. But for generally hospitalized patients, so if your patients are sick enough even at home and you are managing it at home, then you should still consider that patient deemed hospitalized and give anticoagulation. And in that setting, possibly oral anticoagulant in the form of NOACs are the most commonly used one, because it's difficult to give injections at home in a COVID-19 situation. But in the hospital, Injectable drugs are more easy to be given, and we almost always prefer in the hospital setting subcutaneous injections of low molecular weight heparin. I guess the reason for that is also one has to highlight this that NOACs, though they do not need monitoring, are difficult to, their effect is difficult to reverse if there is a need. That means that if somebody is on NOACs, not all NOACs are easily reversed, like heparin or these sort of drugs. And they are pretty long-acting drugs as well. So if you start bleeding until you do something, it is difficult to control that as well. So in a hospital setting, low molecular weight heparins are possibly preferred for that reason as well. For patients at home, there is no evidence so far, or no meta-analysis or systematic review has shown so far that giving anticoagulation at home or people at home with mild disease to have any benefit whatsoever in the mortality or in the outcome. The reason being also that people who are at home should be mild disease, because all the guidelines say that something more than the mild disease, you should be under some sort of medical supervision in a hospital setting. It is difficult to actually look into those data and come out with reasonable confidence what is the inner meaning of that. But generally speaking, for milder disease, anticoagulation is not needed. Somebody who is to be hospitalized needs anticoagulation. And I'll also highlight, if time permits, Sana, that we are now seeing in a post-COVID situation that patients with normalization of the inflammatory markers, i.e. the most common ones are, as you know by now, is CRP and ferritin and stuff like that. With normalization of the inflammatory markers, D-dimer remains very, very high. And whether the ongoing, as many of my esteemed colleagues have already pointed out, the pathophysiology of COVID, that whether there's ongoing microthrombosis, ongoing microthrombus formations happening in the patient is difficult to say with confidence. Some studies have come out that as many as 25% of post-COVID patients can have persistent high D-dimer, possibly due to ongoing microthrombus formation, and might need some form of anticoagulation for a longer period of time than estimated 2 weeks of anticoagulation for patients in the home setting. So this is an evolving field, and persistent of D-dimer would something will be of interest to all of us, because as we know from various anecdotal stories from news media, that people with COVID reasonably well gone home and suddenly collapsed, and people have lost their friends and family. Whether this microembolization is continuing for a longer time than we currently estimate, it's something to look forward to. Thank you.
Thank you. Thank you, Dr. Syamasis. And you started with a very prudent statement that this is still an evolving thing. COVID-19 infection is still being read, researched, and it's very difficult to say something with the concrete conclusion. But obviously, whatever we know at present, this is the status that you shared. So thank you so much, sir. My next question is for Dr. Aviral. You were talking about using certain terminologies, Dr. Aviral, VKAS and NOAS. So what are the disadvantages seen with NOAS agents?
So again, great question, Sana. NOAS are relatively newer, and like I mentioned earlier, they act directly and directly block the proteins that are responsible for a part of the coagulation cascade. So, the weakest link in any chain is the strength of the chain. So the moment you block the weakest link or you stop it, the chain strength reduces, and that is what you try to do with anticoagulation. You reduce the chance of forming a clot. Now, unfortunately, because these are directly acting drugs, that's the main disadvantage. If you want to reverse the blockage, it is very, very difficult to do so. You basically have to wait for the body to form either a new protein that is not blocked, or you have to figure out a way to unlock the protein from that is blocked by your agent. So that is your biggest disadvantage. Reversal of anticoagulation. What do you do for somebody who's now bleeding and you have anticoagulated? With our legacy drugs, the VKAs, we had a very, very easy solution. If it was mild bleeding, you gave them a reversal agent like vitamin K. They block vitamin K, you give them vitamin K, they start working again, and you're fine. For more severe bleeding, we just replace the coagulation factor. So we give something called FFP, which is a blood product, which basically gives the patient new coagulation product, proteins, and then their blood starts clotting normally again. That does not work with the newer anticoagulation agents. We have to use other fancier agents. Though there's a drug called dabigatran, which has an antibody. So you have to inject the antibody to dabigatran, which is the antidote that stops the dabigatran from binding to proteins, and then the blood starts clotting again. Otherwise, you have to give something called 4-factor prothrombin complex concentrate, PCC, which basically is a very, very high dose of coagulation factors into the person. Again, you have a risk factor that you can go too much the other way, and these things often cause strokes or thrombosis or new clots to form. So these are the primary difficulties and the primary disadvantages of NOACs. But there are also a lot of advantages. If I know I take one tablet of NOAC, I know I'm going to be anticoagulated for roughly 12 to 14 hours. So the same thing that is a strength is also weakness, like for many things. Your greatest strength is also your greatest weakness.
True. Very, very truly said, Dr. Aviral. Uh, I will put my next question to Dr. Ajoy. Dr. Ajoy, what is to be done in case of emergencies like surgery for patients on anticoagulation therapy?
This is a very common situation. We do see, surgical colleague is asking us that he or she is on anticoagulation, so he is going to operate on them and what to do. There are few things you need to assess before whether this patient is on injectable anticoagulation or not. If they are on injectable, say for example, heparin, short half-life is very short. So you can stop them for 6 hours and then you can proceed for operation. If they are on low molecular weight heparin, again, that's not a big deal. It can be 14 to 16 hours. So at best, you can defer for 1 day. But if it is an emergency surgery, then you got to analyze the nature of the surgery, how big that surgery is, and what is the amount of bleeding it can cause. Say, for example, few surgery like aortic aneurysm surgery, transplant surgery, knee transplant, hip transplant, they can cause a lot of bleeding. So there you need to have at least INR at below 1.5 before proceeding for surgery. Or if you have a surgery, just say for your hernia operation, so you don't get any blood loss. So there even you can go for stoppage of your drugs. Again, the drug, which drugs you are on, say oral drugs. If it is a vitamin K one, then again, the vitamin K can, the half-life is quite a few days. Then you need to stop the drug for major surgery 2 days before and 2 days after surgery. If it is a moderate risk, then you need to stop 1 day before and 1 day after surgery. If it is just minimal blood loss, you can stop that day and proceed for surgery and then restart from the, because the risk of thrombogenesis is again judged. If your patient has got a Charter score is very high, then if you stop that for prolonged period, then you might stop the bleeding, but he can have a stroke in between, post-operative period. So these are the points you need to keep in your mind. But in case of NOACs, since the half-life already Dr. Roy has mentioned that 16 hours, 12 to 16 hours. So you got to stop for 1 day before and 1 day after. And if it is a major surgery or major risk of bleeding, but if it is just minimal risk of bleeding, you can stop that period of, and after say 1 day, you can restart. So these are the things you need to find out: the drugs which he or she is on, what is the nature of the surgery you are going to have, what is the chances of bleeding, and what is the risk of your patients having thrombotic events if I stop that. And after assessing that, you got to stop it, but the duration of stoppage will vary from surgical nature as well as from the thrombogenic episodes.
Thank you, Ajoy. So I could make out 4 major factors broadly. I'm sure there must be other factors also. But for doctors to make a case-to-case assessment, they need to see what kind of anticoagulation therapy the patient is on, and the kind of surgery, the risk of bleeding, and the risk of thrombosis if the therapy is stopped. So four broad categories I could, make out from your answer. So thank you so much, Dr. Ajoy. Sir, my next question is for Dr. Partha. Dr. Partha, what is the role of anticoagulation in pulmonary embolism? I'm sure Dr. Ajoy has broadly covered, major types of surgeries or major kind of interventions, but then we are now asking specifically. So what is the role of anticoagulation in pulmonary embolism or DVT?
Okay. Now in hospital setting, this is the most commonest problem which requires anticoagulation. That's pulmonary embolism is blood clots, microclots that are produced in the vein. They pass out usually from the leg veins and they pass out into the heart and from the heart to the lungs. So if it goes into the lungs, it produces as an emboli and there is a pulmonary infarct. So usually the patients who are bedridden for a long time, they may grow those sort of veins, clots in the vein, in the calf muscles and thighs. For a major surgery, especially orthopedic surgery, they can have this sort of problem. Dr. Syamasis has already discussed on using anticoagulants in critical setting. These are basically to prevent the pulmonary embolism. And deep venous thrombosis is part of that. So usually they produce a deep vein thrombosis and those thrombosis break out, small clots from the thrombosis break out and they produce an emboli. That emboli goes into the lung. So it is a pulmonary embolism. So basically part of the same problem. So what to do is to prevent this thing. For prevention, we have to use anticoagulants. In major surgeries, we use low molecular heparins and unfractionated heparins and oral anticoagulants, preferably NOACs. So newer acting anticoagulants, they work fast. They work within a few hours and they are short acting also. So you can adjust accordingly. But if you already have a deep vein thrombosis, that has to be confirmed with an Doppler study and all. So if you already have an established pulmonary embolism, that has to be confirmed by a CT angio and all. So that in that case, heparin is the most important therapy. You have to give a short course of heparin according to the patient, and you move on to a oral anticoagulant. And in that cases, NOACs are preferred because you don't have to do a bridging. In cases of coumarin and warfarin, you have to bridge. You start with heparin and you start with the anticoagulant also along with it, but you have to continue for a long period of time, maybe a few months even, and you have to monitor seeing the progress of the, and this pulmonary embolism may be very serious. Small emboli will only present with, usually what happens, the patient had a surgery 2 days back, suddenly the patient has an option, an episode of respiratory distress, then there is hypoxia, then there is a low-grade fever, chest pain, and the patient becomes very sick. So we have to find out that there is a clot that has basically moved from the veins into the pulmonary artery and into the lungs and producing pulmonary embolism. In that cases, you require a long period of anticoagulation. It may be even fatal in some cases. It's a dangerous disease, basically.
Right. Thank you, Dr. Partha. I have 3-4 more questions, and we just have 4 more minutes left for this session to conclude. So we'll just now try to rush through those 4 questions with shorter replies if possible. This is a very humble and kind request now, sir, because these are pertinent questions I see here. My next question is for Dr. Syamasis. What is the role of OSC in patients undergoing orthopedic surgery?
As I said to my answer before, it is the orthopedic surgeries which brought anticoagulation in limelight. The current understanding of anticoagulation for prophylaxis or prevention was first brought up in orthopedic surgical cases, mostly in fractured neck of femur in older people. Because these are the common patients who get fractured neck of femur for insignificant fall. And it is these patients over 80 odd or around 80 years old, people started having this pulmonary embolus and death. Hence, this all came in the limelight. So absolutely yes, for orthopedic surgery, anticoagulation is a must unless there is proper contraindication of not giving anticoagulation. I'm telling proper contraindication because people often take softer contraindications as an alibi of not giving it. So it has to have a proper, cause of not anticoagulating somebody. Thank you.
Thank you, Dr. Syamasis. My next question is for Dr. Aviral. How to manage patients on anticoagulation who develop low platelet count like dengue?
So a very, very good question. It's something that happens when every time we have dengue. The question then comes up to what is the risk of them bleeding versus what is the risk of them clotting. You have to do the determination every day, and then you make a call on whether to continue with the anticoagulation or not. You might want to switch for a short period of time to a short acting anticoagulant if you're really concerned about the risk of bleeding, but you're also really concerned about this risk of clot formation. If the patient is low risk of clotting, then you just turn the anticoagulation off, wait for the disease to recover, and then you can always restart. But if they're much higher, what we would normally do is switch to a short acting agent. And once they are better, we go back to whatever they take. But if they have a high risk of bleeding or the platelet count is really low and the risk of bleeding is much higher than the risk of clotting, we just stop their anticoagulation, treat their
Right.
Once they get better, we restart them on their anticoagulation.
Thank you, Dr. Aviral. So it's a very close monitoring and assessment we need to do, I think, from your answer. That is what I could, take away from your answer. Thank you, sir. My next question is for Dr. Ajoy. What is the role of anticoagulation card?
So this is card like your credit card is available in Western world for many diseases like diabetes, epilepsy, those who are on anti-epileptic medications and anticoagulation. The logic behind carrying this card is that, say for example, if someone has got an accident and he is unconscious, he is on anticoagulant. So immediately doctor is not going to get any history from him. So he'll understand from that card that this guy is on anticoagulant. So chance of bleeding will be very high. Chance of giving some procoagulant may be needed. So if they're on, say, for example, warfarin, so you have to give them vitamin K, you have to give them PCC or fresh frozen plasma, whatever is available. So this is very important, and that card should mention the nature of the anticoagulant, how long they have been taking them, the date of initiation of the drugs, and the dose, and how frequent he is monitoring that. That has to be mentioned in that card. And I think this is very important thing. And those who are on this medicine try to carry, even if it is not a card, some form of information they should carry in their purse or wallet, so that someone should know in case of any emergency that what is going on.
Very true. Dr. Ajoy, thank you so much. I think from what I understood is that this card or similar medical history cards could mean a difference between life and death in emergency situations, practically. True. So my last question is for Dr. Partha. Sir, is COVID vaccination associated with higher risk of thrombosis? We are talking about the vaccination, particularly here, COVID vaccination.
Yeah, so many misconceptions and ideas about COVID vaccination. There is no data till now that it says that there is increased thrombosis. Basically, the side effects of vaccinations are not very severe. People are asking basically already on aspirin or on anticoagulants whether they stop the medications before the vaccination or not. There is no such indication, at least not with aspirin and all. And any injectable may produce a blood clot in the local area, but as such, vaccination producing thrombosis is not known.
Thank you, Dr. Partha. Thank you for clarifying that. So with that, we come to the closing of this webinar. It was a pleasure to talk to our panel of experts here. I'm sure even our audience would learn a lot from this discussion. Thank you for joining us today, Dr. Syamasis, Dr. Aviral, Dr. Ajoy, and Dr. Partha. It was great to have you here. I would also like to thank all our audience for viewing this, and I'm sure it is insightful for them. This is a TOI and Biological webinar on anticoagulation insights for clinical management. We hope to have many more such enriching discussions in the future with you again. So thank you. Thank you so much. Thank you, sir.